Hello and welcome. My name is Christian Hemp. I work for the Food and Drug Administration, and I'm very pleased to moderate this session today. The title of the session is Pregnancy Pick and Mix, and I welcome you all and thank you for your interest. We have a pretty nice lineup of speakers that I'm excited to hear. Some housekeeping items first. Want to let you know that the session is being recorded, can be watched later. Each speaker has 10 minutes to talk. Please submit your questions in the Q&A tab, and we will post the questions after each speaker concludes their presentation. And with that, I welcome Elizabeth Suarez on her presentation about prescription medication use and baseline health status of women with live birth deliveries in a national data network, the Sentinel Distributed Database Mother-Infant Linkage Table.
Thank you. Hopefully you can both hear me and see my screen.
Yes to both.
Okay, excellent. Okay, so I'm going to be talking about this descriptive analysis that we did among mothers with live birth deliveries in the Sentinel Distributed Database Mother-Infant Linkage Table. So first, I'll note that this project was funded by the FDA, and we have nothing to disclose, and we'd like to thank all of the data partners who provided data to be used in this analysis. So the FDA Sentinel Mother-Infant Linkage Table is part of the Sentinel Distributed Database, which is a national network of routinely collected electronic health data in the US and predominantly includes administrative claims data. And so in order to meet the FDA's goal of being able to use this national resource to study maternal drug exposures during pregnancy and adverse infant outcomes, such as major congenital malformations, it's necessary that we link the mother and infant records together in the administrative data. So in 2018, they undertook a project to add to the Sentinel Common Data Model a table of linked mother-infant pairs at specific data partners. So the aims of this particular project was to characterize the mothers with live birth deliveries that were included in the mother-infant linkage table, and also to informally compare the characteristics between the live birth deliveries that could and could not be linked to an infant, which informs future analyses where we're restricting our cohort to our live birth deliveries and somewhat informally checking if we have any potential selection issues to worry about. So as I mentioned, we're using the Sentinel Distributed Database as the data source for this project. And so at the time of this analysis, there were 6 data partners that were populating the mother-infant linkage table with live birth deliveries and with infants. These 6 data partners included both privately and publicly insured women. And each data partner did their linkage process of the live birth deliveries to the infants separately using data they had available to them. Predominantly, this included membership IDs for linkage. And then once we had that compiled table, we selected all singleton live birth deliveries for analysis. So that included women aged 10 to 54 years at the time of their delivery. And this included data from 2000 through 2019. We had 2 cohorts for analysis, our linked singleton deliveries that were linked to an infant, and then our not linked cohort, which is our deliveries that were unable to be linked to an infant. We defined a long list of baseline health conditions and lifestyle factors for the mothers, so any comorbidities and factors like smoking or alcohol use. We also defined a list of pregnancy-related conditions, such as gestational diabetes, gestational hypertension, and we used validated algorithms when we could to define these. We were interested in knowing pregnancy history in the database. And of course, this is US claims data, so we don't have continuous enrollment for these women in all of adulthood. So this variable really reflects just what we're able to see in their database while they're enrolled in their public or private plan. And then we looked at a long list of medications and broadly grouped them by indication and class. Today, I'm going to focus on these broad indication groups for time. And these are just outpatient pharmacy dispensings, not inpatient administrations. So here are some key study design elements. Live birth deliveries were identified using diagnosis and procedure codes, and then we used a validated algorithm to assign gestational age at birth and count backwards to assign an estimated pregnancy start date. Mothers were required to have 391 days of continuous medical and drug coverage prior to the delivery date to ensure that we could observe their full pregnancy, and also a 90-day pre-pregnancy period. And then infants in the linked cohort weren't required to have any specific enrollment, but they did have 1 day of enrollment in their first year of life. Then we defined medications based on overlapping day supply, either with pregnancy or with this 90-day pre-pregnancy period. And we also stratified medication use by trimester. And we defined our baseline characteristics for the mothers in this 90-day pre-pregnancy period through the end of the first trimester, because this is the window we'd be interested in using in our future analyses of malformation risk. And we looked at healthcare utilization in the 90 days before pregnancy start. And then also, as I mentioned before, pregnancy history and various pregnancy conditions. So in our linked cohort, we were able to identify more than 1.9 million pregnant patients who had 2.3 million live birth deliveries available for analysis. In the not linked cohort, there were 469,000 pregnant patients with more than 404,000 linked deliveries. You can see that maternal age was a little bit different between the groups. The linked cohort on average was a few years older than the mothers in the not linked cohort. And when we look at the age distributions, we can see that predominantly the linked cohort is in women aged 25 to 39, where we have a larger proportion of the younger age groups in the not linked. But I'll also note that among our oldest mothers, more of these mothers ended up in our not linked cohort. We do have race and ethnicity in some of our data partners, but you do see here that unfortunately it's quite incompletely captured. So some of our data partners have better capture on this than others, and some don't have it at all. So some key pregnancy conditions that we looked at. Preterm birth appeared to be slightly more common in the not linked cohort than the linked cohort, while cesarean delivery and gestational diabetes appeared to be more common in our linked deliveries. Gestational hypertension and preeclampsia were fairly common between the groups and met expected proportions based on other reports. And then we see that the linked deliveries were more likely to have pregnancy history in the database. And some of these differences can probably be attributed to the fact that our linked deliveries are slightly older mothers. Here is a list of some of the baseline health conditions we looked at, not all. The linked deliveries are in dark blue, the not linked are in the purple. And you can see that there's not huge differences between the two groups. I'll highlight that the not linked deliveries have slightly higher prevalence, recorded prevalence of some mental health disorders, of their tobacco use. And then the linked cohort had slightly higher prevalence of acquired hyperthyroidism. And I think some of these differences can probably be attributed to some of those differences in maternal age that we saw. And then this gives you a really high overview of our medication use. This is any use in pregnancy comparing our linked to our not linked. And we see that anti-infectives, which includes antibiotics, is by far our highest category, pretty similar between the two groups. Our mental health and central nervous system agents are also relatively common. And we see that our endocrine medications are slightly more common in our linked cohort than are not linked, but relatively similar proportions of use across these two cohorts. Now I'm just focusing on the linked cohort because this is the population that we'll do most of our analyses in the future. And I'll just highlight a couple of groups. So this is looking at medication use in pre-pregnancy, first trimester, and third trimester. So we can see kind of trends over pregnancy over time. So we see that our anti-infective agents, our antibiotics and antivirals, are pretty consistently used throughout this time period. We have our gastrointestinal agents that peak in first trimester. This is mostly due to those antiemetics that are used to treat nausea and vomiting in pregnancy. Endocrine therapies are also quite common. This includes progestins and estrogens, but also antidiabetics. And then respiratory therapy agents were also somewhat common. This includes drugs for asthma, COPD, things like that. And our central nervous system agents, this includes things like our antidepressants, anti-anxiety medications. You can see this decreases as we move through pregnancy, which we've seen in other studies. And then finally, I'll just highlight the analgesic category here, which includes our opioids and NSAIDs and other drugs like that. So we also did look at this by maternal age. And you can see, looking at this in the linked cohort, that generally medication use was higher among our younger mothers, especially for the anti-infectives. You see the same trend with the gastrointestinal medications in the black line here, but you see the opposite trend happening for our endocrine medications. So we specifically looked at these gastrointestinal, or I'm at least gonna highlight for you now the gastrointestinal and the endocrine medications. So we can see which drugs are contributing to those agencies. And we see that a lot of our older mothers are using, have exposure to estrogens and progestins. And so these drugs are used in infertility. They're also sometimes used for treatment of recurrent preterm birth. And both of those things are going to be more likely to be found in our older mothers. Here we see the gastrointestinal trends are predominantly due to antiemetics. And this matches trends showing that nausea and vomiting symptoms are a bit more common in our younger mothers. So there's some strengths and limitations to this analysis. So at this time, we had a very large cohort of 2.3 million linked deliveries. If you were interested in having a shorter duration of enrollment, if you're only interested in looking at enrollment around the time of the delivery, this number could be as large as 4.1 million and even larger as data accrues. We know there's some limitations of administrative data, including incomplete capture of race, ethnicity, and some lifestyle factors like smoking. And of course, medication exposure is due to dispensing and not consumption, so there could be some misclassification. We capture only live births, and this particular analysis was limited to singletons, but multiple gestational pregnancies are captured in the database for future analyses. And we didn't capture reasons why linkage was not possible for the not linked deliveries, but it could be related to the fact that mothers and infants are sometimes enrolled under different plans. And it also can be contributed to the fact that there's misclassification in delivery status. So this is a great, a valuable resource for future medication monitoring during pregnancy, including both publicly and privately insured women. We didn't see any suggestion that there were strong selection factors for our linked cohort. And in general, we observed some expected trends in maternal medication use. Thank you.
Thank you very much, Elizabeth. Are there any questions? I see that Sonia raised her hand. Sonia, go ahead.
Hi, Lisa. Great presentation, beautiful slides. Thank you so much. I was wondering if more than one center contributed to the data. Did you check if the linkage was different between different databases or regions?
Yeah, we have, so in this particular project, we didn't look too much in just the linkage percentage. We could focus more on the characteristics. There is more information on the Sentinel website about breaking down the linkage success, the linkage rates essentially by, care setting of the delivery, age, other factors that you might be interested in. So yeah, if anyone is interested in that, you can search for the mother-infant linkage table in Sentinel. And there's a great information page on the Sentinel website about other differences in the specific linkage rate.
Thank you for providing that information. I think it's time to move on to the next speaker. Thank you, Elizabeth. The next speaker is Lionel Larsen, and the presentation will be about increasing prescriptions of misoprostol dispensed before delivery in Belgium from 2003 to 2017, evidence from healthcare administrative database. Lionel? Please make sure you're unmuted.
Okay, can you hear me?
Yes.
And can you see me?
Yep, your slides and yourself.
Okay. Thank you very much for inviting me here today. My name is Lionel Larsen, and I'm working at the public health schools of ULB in Belgium, Brussels. And I'll talk today about the use of misoprostol during pregnancy, at the end of pregnancy in the context of Belgium. So the study has been conducted in collaboration with the Intermutualistic Agency in Brussels and the Clinical Pharmacology Unit of the University of Toulouse in France. and we have no conflict of interest to disclose. So misoprostol is a prostaglandin E1 analog that for which the original preparation, Cytotec, is only approved for the treatment and the prevention of gastric ulcers. But in some countries, more recently, there are other preparations that have been registered for indication in gynecology and in obstetric. In the context of Belgium, there was only one drug that contained only misoprostol up to 2016, and it was Cytotec. From 2016 to 2018, there were another drug, Misodel, marketed in Belgium, and this one was approved in obstetric and gynecology, but this second drug was much more expensive, not reimbursed, so it has been almost not used in practice and has been withdrawn from the market at the end of 2018. So in a context where almost the only drug available containing misoprostol was the Cytotec, the research question was the Cytotec used outside of its approved indication at the end of pregnancy across a 3 study period between 2003 and 2017. So in Belgium, we have not so much study about drug utilization during pregnancy, but we have quite potential to improve this knowledge because there are quite a lot of health administrative database of good quality. And this project was the opportunity to explore one of them, the permanent sample. So the permanent sample is a 2.5 representative sample of social insurer in Belgium. Each patient in the database has a unique pseudonymized identifier, and the database captures all medication reimbursed dispensed in the community pharmacies. And one particularity of this database is that the database captures also the inpatient medication. So all medication prescribed and dispensed in hospital pharmacy are captured, included the non-reimbursed medication. Are also available in this database, among other information, ATC code for each drug, the quantity dispensed, the date of dispensing, the patient age, region of residence. And the pregnancy can be identified in the database with the code of reimbursement related to the delivery. So since the data were available from the year 2002 to the year 2017, and as we wanted to study the trends in the prescription of misoprostol, we decided to establish 3 study periods of 3 years, 2003 to 2005, 2009 to 2011, and 2015-2017. We extract all the women that gave birth, excluding the birth delivery before 6 months. And we determine the proportion of pregnancy with at least one prescription of misoprostol Cytotec in the database with the code ATC A02BB01 only corresponding to Cytotec in Belgium. And we determine the prevalence for 2 periods of exposure, the 7-day period preceding the delivery and the day of the delivery. The proportion have been computed for each study period. So because misoprostol Cytotec can be used off-label to induce labor, but also to treat postpartum hemorrhage, we have decided to explore 2 period of exposure, and this table present the prevalence of misoprostol Cytotec prescribed and dispensed at the end of pregnancy during the 7-day period before the delivery. So in total, in the study, there were 23,000 pregnancies included, and in each period of 3 years, about 8,000 pregnancy in each period. So In the first study period, there were a bit more than 0.1% of pregnancy exposed to at least one prescription of Cytotec, and this increased up to 0.6% in the last study period. So for the second period of exposure, so the prevalence of misoprostol prescribed and dispensed the day of the delivery, we can observe a similar increasing trends and a higher prevalence. So going from 0.4% to 3% of the pregnancy exposed to at least one prescription of Cytotec the day of the delivery. So we assume the prescription of Cytotec dispensed before the delivery to be mainly to induce labor and not to treat postpartum hemorrhage. And the day of the delivery, it will be both of them. So the increased trend that we observe in our study can be explained by several factors. So for 2 decades now, we have growing evidence of effectiveness in the use of misoprostol to induce labor or to treat postpartum hemorrhage. There were quite some guidelines to promote the use of misoprostol in obstetric, also from the World Health Organization, but also from different institutions of obstetrician around the world. And there are quite a lot of advantage to use Cytotec, and among them the facility to store it at room temperature, and it's very low cost. So, but in the other hand, some element came against its utilization. Already in 2001, the manufacturer of Cytotec warns against its use in pregnancy. In 2005 and in 2013, the French National Agency for Medicine has warned about the risk associated with the use of Cytotec in obstetric and gynecology. And the drug has been finally withdrawn from the French market in 2018. More recently, in March 2020, the German Federal Institute for Drug and Medical Device has informed about few reports of severe side effects when using Cytotec outside the approved indication. Indeed, the off-label use of misoprostol has been associated with a risk of uterine rupture and obstetric hemorrhage. So one reason might be the difficulty to have a correct dosage with the misoprostol under the formulation of Cytotec. There are tablets of 100 microgram when the dosage is about 25 microgram. So they need to cut it. So to conclude, the proportion of pregnancy exposed to at least one prescription of misoprostol Cytotec dispensed at the end of pregnancy has increased between 2003 and 2017 in Belgium. And more attention should be paid to this clinical practice, given that the debate is still ongoing concerning the safety of its use. Okay, thank you.
Thank you, Lionel, for the very interesting presentation. I think it will be interesting to see how the utilization of misoprostol will continue after your study period, given what is covered in the medical literature regarding its risks. Are there any questions? So here's a question from Sasha Dublin. She is asking, can you provide some more context? What proportion of pregnancies or deliveries are usually induced? And what is the usual approach of to cervical ripening? These rates of use of Cytotec seem very low to me, given that in the US, something like 25 to 30% of pregnancies are induced and many need cervical ripening. What is the alternative?
Okay, so we are just looking at this. The other drug that induce labor in Belgium. Belgium is one of the champions in Europe to induce labor. We have a rate of about 25% in the country of induced labor. but many other drugs also are used. So I check oxytocin is used by 62% of pregnancy exposed the day of delivery, and 71% 71 in total, so including the 7 days before. And we have dinoprostone also with quite a high number. So these include the not only to induce labor but also to prevent postpartum hemorrhage. Those drugs are also used, and we cannot distinguish both. About the rate of misoprostol, it will be interesting to see a bit how it go now after the French market, that they withdraw the drug, and now that we have a new drug that just arrived in May 2021, Angusta, that is also misoprostol in 25 microgram. So it will change. Yes, it's not that high maybe, but still 4%, 3.6% if we do both the 7 day and the day of delivery is still an important proportion, I think.
Mm-hmm.
Yeah.
Okay. Sasha, does that answer your question? If not, you can continue to type in the Q&A box and we can address it later. Oh, no, Sasha, I think the audio for the audience is generally off. So I think the only way to interact is through the Q&A box or the chat. But if you have follow-up questions, please type them. And if there's time at the end, we will address them then. Thank you, Lionel.
Yeah. So that's no more question?
No more questions at this time. Thank you. And we are moving on to Thuy Tai, who will present on the effects of gadolinium-enhanced MRI exposure during pregnancy on neonatal intensive care unit admission.
Thank you. Can everyone see my screen now?
Yes.
Great. So hi everyone, my name is Thuy. Today on behalf of our team, I am sharing our project about risk of neonatal intensive care unit admissions after gadolinium contrast exposure during pregnancy. And this project was funded by FDA, and the presentation here represent the opinions of the authors, not necessarily from FDA. Dr. Wunderstein and Rasmussen have received some research funding or consultant fee that are unrelated to this work. All the members don't have any conflict to disclose. So gadolinium is a contrast agents that are used to provide additional diagnostic information for MRI scan. In a reverse study used mostly rapidly insured population in Sentinel database, the author found that 1 per every 860 live-born infant was exposed to gadolinium MRI during gestations. And we can see that the majority of the gadolinium MRI exposure occur in the first trimester, which is a different picture as compared to non-contrast MRI, typically happen in the second and the third trimester. Gadolinium is known to deposit in various body tissue and can cross the placenta, and this raised a concern about the safety of gadolinium use during gestations on the fetus. A reverse study conducted in 2016, they found that gadolinium exposure were associated with an increased risk for stillbirth or neonatal death, as well as other fetal outcome. However, in this study, the author compared gadolinium MRI exposure woman with no MRI woman, and this resulted in a concern about confounding by indications. In this study, we evaluated the safety of gadolinium MRI during pregnancy on risk of NICU admission compared to the women who use no gadolinium MRI during pregnancy. So let's move to the method. So we used the National Medicaid data from 1999 to 2014 to capture maternal baseline characteristics before conceptions, the use of MRI during gestations, and also NICU outcome after delivery. Conception date is typically not available in the administrative claim data, so we link Medicaid to Florida birth certificate to capture clinical gestational age estimate, and from there we calculate back the conception date. For the delivery that could not be linked to birth certificate, we use a validated algorithm to estimate conception date. Therefore, we could appropriately measure the timing of MRI during gestations. We follow the woman from 90 days before conception to 30 days after delivery. Our exposure assessment window was from conception to 1 day before delivery. Index day is the date of the first MRI, and we exclude the deliveries that have the first MRI with unknown contrast status or the MRI for the pelvic or fetal evaluations. We further exclude unlinked live birth or that delivery is multiple gestations. We also remove the mother with a malignant neoplasm or exposed to any teratogenic drugs. We remove the delivery that have a fetal abnormality diagnosis between conception to 1 day after the MRIs. And the last exclusion criteria is we remove the pregnant woman that is exposed to gadolinium MRI or have an unknown MRI, unknown contrast MRI within 30 days before delivery, so that we can avoid a potential of exposure misclassifications. In our primary analysis, the outcome evaluation window was 7 days after delivery, and we adjust for the potential risk of confounder with various assessment window from 90 days before conception to 1 day before delivery. So in terms of analysis, our primary outcome is NICU admission was based on a validated list of CBT code on both infant and maternal record within 7 days of delivery. And to estimate the adjusted risk ratio, we use a generalized estimating equation model with SMRW method. And we also conduct several sensitivity analysis to evaluate the robustness of our finding. First, for the pregnancy exposed to multiple MRI during gestations, we update the exposure status from no gadolinium to gadolinium if the second MRIs were gadolinium and met both our inclusion and exclusion criteria as described above. Second, we vary the assessment time window from any time during gestations in the main analysis to within the first 20 weeks of gestations or also by trimester. And lastly, we have a secondary NICU outcome definitions where we expand the outcome assessment window from 7 days to 30 days and use a broader list of CBT code to define NICU outcome. So let's move to the result. So we start with over 11 million linked live births within MAX data. After imposed maternal and infant continuous enrollment requirement, we have 1.3 million linked left. And among them, 14,000 exposed to at least one MRI during gestations. And after applying all the exclusion criteria, the final cohort includes 5,900 delivery, and 771 of them exposed to gadolinium MRI, and the remainder exposed to no gadolinium MRI. By using either primary NICU or secondary NICU definitions, the proportion of infants having NICU admission in the gadolinium group was similar to no gadolinium group. And this table compared the maternal characteristic before and after apply the adjusting. So before apply any adjustment, we can see that gadolinium model tend to have younger age, more likely to enroll into Medicaid due to disability, and exposed to MRI in the earlier year and live in the rural area. And the gadolinium model also more likely to receive the head MRI as the earlier gestations compared to the non-gadolinium mother, and the gadolinium mother also less likely to have prenatal care. And some other unbalanced covariates include opioid use, multiple sclerosis, and the last one is conditional related to gestations. And after apply the weighting, all the covariates are well balanced between the two groups. So this slide summary our result. So in our primary analysis, where our exposure evaluation window during any time of gestations, and we use a primary NICU outcome definitions, the proportion of infants in the gadolinium group having NICU admissions were 7.7% and 8.8% in the no gadolinium group. Our adjusted risk ratio was 1.03, and with a 95% confidence interval for 0.76 to 1.39. In our sensitivity analysis, we observe a consistent result as compared to the main analysis as shown in this forest plot. So to conclude, our analysis found consistent result indicate no association between gadolinium MRI exposure with the NICU outcome admissions. And in addition, by using an active comparator design, we address biopsy by using a combination of claim and vital statistic record. We use validated algorithm to identify pregnancy outcome and also estimate conception date. Although we have a consistent result among all the analysis, replication of this study in a different population would be desirable. And lastly, for other pregnancy outcome may warrant further examination so that we can have a better understanding about potential adverse effect of gadolinium among pregnancy population. And thank you.
Thank you, Thuy. Are there any questions? Maybe while people are typing their questions, I asked one. I'm curious whether you looked at reasons for NICU admission, because you know, your outcome combines them, and I think there are some big ones that may eclipse others. For instance, I think the big reasons for NICU admission are probably preterm birth and maybe opioid syndrome or things like that, and that may cover up smaller ones that might be imbalanced. Did you look at any other outcomes?
No, we in this project we do have other outcome is stillbirth or neonatal death. And for the reason of NICU admission, we did not further like dig down into why that baby was admitted. But like given the fact of we have an active comparator design, we compare the woman who is exposed to gadolinium MRI versus no gadolinium MRI, and with like the balance, all the covariates as we adjusted for are well balanced. So we believe that like for other factor that's resulted into NICU would be balanced for between the two groups as well.
Mm-hmm. Thank you. And there was one question coming in from the Q&A board, again from Sasha Dublin. Thank you for your question. Great work, very interesting. Maybe I missed it, but can you remind us what is the potential mechanism by which you thought gadolinium might lead to NICU admission? How might it affect the fetus, and what other outcomes might that lead to that should be studied in the future?
Yes, so the mechanism of NICU of the gadolinium is may cause a concern. So I will go back to this one. So like so gadolinium can deposit in our in various body tissues, and a RIVER study found that it can be retentions, and for the fetus the organ that's most likely to be retained is the kidney, and this RIVER study found that there was a significant increased risk of gadolinium exposure for the stillbirth or neonatal death outcome as well as other outcome. But in this study, the there was a strong confounding by indications. So that's why there is a need to replicate that study. And the presentation that I show here is only one outcome of a bigger project. As I say, for other project, for other outcome that would need to be replicated is stillbirth or neonatal death. But today I do not present that result at here.
Do you know anything about a proposed biologic pathway by which gadolinium would create neonatal harm?
Yes, so because gadolinium, as I say, like gadolinium can retain into, basically it is used by the mother, and it can cross the placenta. It means that it can affect the fetus. And because gadolinium have two kinds of structure, or if it's when it combined with a ligand, so it's less effect. But it's when it's non-combined with a ligand, it's appeared to be have more toxic effect. And because it can cross the placenta, so it would mean that it can go into the fetus body and retain in the fetus body, and because there are reverse concern that even in the adult populations, in the renal dysfunction population, there was some potential effect of gadolinium among that populations. And because the concern of the fetus and the concern about the reverse study brought up about the potential increased risk of stillbirth or neonatal death when using this contrast agent during pregnancy.
Okay. Thank you, Thuy. There's one more question from Yanmin. Hi, Thuy, great presentation. I wonder what's the reason for excluding infants with fetal anomaly diagnosis? Could this potentially result in underestimation of NICU incidence in both groups and bias the results toward the null?
Yes, so thanks Yanmin for the question. So Yanmin asked us about why we exclude the fetal abnormalities diagnosis here, because like as we can see, we only exclude the fetal abnormality diagnosis most that before index day, because this may indicate that there is some concern already exists for the baby. So one of the reasons that can do the MRI is we have a concern for the baby, and the OB/GYN can order an MRI to check for that baby. So that's why we don't want to create a potential confounding by an existing concern that happened before the MRI. So that's why we apply that exclusion criteria.
Okay, thank you very much, Thuy. We're going to move on to the next speaker.
Thank you. Let me stop share.
The next speaker is Ah-Young Choi, and she will present to us about proton pump inhibitors in pregnancy and risk of preeclampsia, a nationwide cohort study of 1.9 million pregnancies. Ah-Young?
Yes. Can you hear me?
Yes.
And also, can you see my screen?
Yes.
Thank you.
Perfect.
Thank you for the introduction. And hello, everyone. My name is Ah-Young Choi, a PhD student in SKKU in South Korea. Today, I will present on proton pump inhibitors in pregnancy and risk of preeclampsia, a nationwide cohort study of 1.9 million pregnancies. This work was supported by the National Research Foundation of Korea, and all the conflicts of interest were outside the submitted work. Preeclampsia is a pregnancy complication which is clinically defined by high blood pressure and proteinuria. Preeclampsia affects around 3 to 8% of pregnancies worldwide, and it is one of the major causes of maternal mortality. To date, the only definite treatment option for preeclampsia is delivery. So the problem is that if preeclampsia is severe and the baby needs to be delivered early, this premature birth might be leading to some neonatal complications. Recent preclinical studies have suggested that proton pump inhibitors have preventive effects on preeclampsia. by decreasing the soluble FMS like tyrosine kinase 1 and soluble endoglin, which are shown to be elevated in pregnant women with preeclampsia. However, studies in humans are limited and present conflicting results. So therefore, our study's objective was to evaluate the association between PPI use in pregnancy and the risk of preeclampsia. We used Health Insurance Review and Assessment Database of South Korea from 2011 to 2018. This database covers the entire population in South Korea of more than 50 million populations. And individuals are continuously enrolled unless they are disqualified due to emigration or death. So our HERA database contains information on patient characteristics, diagnosis coded by ICD-10, procedure, prescription in both outpatient and inpatient settings, and lastly, a medical service utilization. Previous validation studies comparing the diagnosis entered in the claims database in our HERA database with the electronic medical records have reported that the overall positive predictive value was 82%. Our study population was all pregnancies that resulted in live birth between 2013 to 2017, and women aged 19 to 44 years at delivery were included. Our exposure of interest was proton pump inhibitors, which are all prescription drugs in South Korea. We defined the exposure as at least one PPI prescription during 4 windows, which are any time during pregnancy, first, second, and third trimesters of pregnancy. As our claims database did not contain the information on gestational age, we estimated the pregnancy duration based on the national statistics and the algorithms developed using the healthcare database. So the pregnancy duration was assigned as 245 days for women with preterm related diagnosis and 273 days for all the termed pregnancies. And also to examine the dose-response relationship, we classified the exposure into 2 groups by defined daily dose. So first, 10 or below 10 DDD, and second group was more than 10 DDD. For the comparator groups, we defined 2 groups. First, unexposed to PPIs from 90 days before the start of pregnancy to delivery, and second, exposed to histamine 2 receptor antagonist as an active comparator. When comparing with the H2RA groups, we excluded women who received both PPI and H2RA from both groups. For the outcomes, we examined all preeclampsia and preeclampsia accompanied with preterm birth. And these outcomes are all identified from 20 weeks of gestation. A total of 30 covariates were considered as potential confounders, which include maternal age and insurance type at delivery, nulliparity, multiple gestation, indications for acid suppressive medications, maternal medical conditions including inflammatory disease, medications such as antiepileptics, and lastly, proxies of healthcare utilization. So for the covariates of maternal medical conditions and medications, we assessed these covariates between the 180 days prior to pregnancy onset to the 20th gestational weeks. And again, the outcome preeclampsia was assessed from the 20 weeks of gestation to the delivery. Baseline characteristics were compared between PPI exposed group and reference group using the standardized differences. Propensity score baseline stratification was used to adjust for 30 covariates, and relative risk with 95% confidence interval was estimated using weighted generalized linear models. For the sensitivity analysis, we restricted the cohort to first-time pregnancy to account for the correlation within the women who had multiple pregnancies during the study period. And also, we restricted the cohort to women who gave singleton live birth to eliminate the potential confounding of multiple gestation, which is one of the strong risk factor for preeclampsia. So moving on to the results, this table shows the selected baseline characteristics of PPI exposed group and unexposed group. Before the adjustment, there were some significant differences in baseline characteristics, especially in maternal conditions and medications. However, after the adjustment, all the baseline characteristics were well balanced. Also compared with the H2RA users, after the adjustment, all the baseline characteristics were well balanced. And this table is one of our main results, which shows the risk of all preeclampsia following maternal exposure to PPIs. So compared with the unexposed group, the adjusted relative risk of preeclampsia for women with PPI exposure in pregnancy was 1.26 with a 95% confidence interval of 1.16 to 1.36. However, as compared with the H2RA users, the adjusted relative risk attenuated to 1.07 with a 95% confidence interval of 0.96 to 1.20. And the next figure shows the risk of preeclampsia accompanied with preterm birth following maternal exposure to PPIs. So in this case, numerically decreased risk was observed in second and third trimesters compared with the, numerically decreased risk was observed in second and third trimesters compared with the H2RA users. However, as the prevalence of preterm preeclampsia was relatively low in our population, the estimates were relatively imprecise. Regarding the dose-response relationship, no association between PPI exposure and preeclampsia in terms of DDD was observed when compared with the H2RA groups. And lastly, for the sensitivity analysis, when restricted to first-time pregnancy, the results were generally consistent with our main results. And also, when restricted to pregnancies with singleton live birth, the results were also consistent with our main results. So to conclude, PPI use during pregnancy was not associated with a reduced risk of preeclampsia in our population. We also did not find evidence of decreased risk with higher cumulative PPI exposure. However, as our populations have taken the usual dose of PPIs to treat gastrointestinal symptoms, further studies are required to determine the optimal dose for preeclampsia. Thank you for listening, and I would like to thank all of my co-authors and all members of my research group. Thank you.
Thank you very much for your presentation. I think your study showed very nicely the value of having an active control group. It was really good to see that the point estimates were very different between comparing PPIs to the unexposed versus the active control group that you had. I do have a question that came in from the chat. How did you avoid immortal person time bias, particularly third trimester, since preeclampsia is associated with prematurity and thus cases have shorter opportunity to receive PPIs?
Yes, thank you for the question. And regarding with this part, so therefore we only, let me go back to the slide, please. Actually, sorry about that. Like we didn't assess, we didn't define the third trimester as until the delivery date. Rather, we defined the third trimester as the start from 180 days after the LMP and 245 days after the LMP, until the 245 days after the LMP, as we assigned the pregnancy duration for preterm related diagnosis as 245 days. So sorry about the confusion. So did that answer your question, please?
The question was posed by Sonia Hernandez Diaz, and she added, which means use after the event. So if I may paraphrase, did you exclude or did you assess any PPI exposure after the patient had preeclampsia and delivery then?
Yes, indeed. We excluded all the exposures after the incident events, and we stopped the follow-up, like not a follow-up, but stopped looking the back part as the incident preeclampsia occurs.
Mm-hmm. Okay, Sonia, does that answer your question? So another concern is that they did have shorter periods. Maybe the concern being that they have less opportunity for exposure in the third trimester because their pregnancy is shorter if they have preeclampsia.
So if I so let me repeat the question, then it means like during the third trimester, the preeclampsia, the woman who had preeclampsia with preterm birth had a shorter time window for the exposure. Is it right?
Mm-hmm. Sonia, since you're a panelist, I think you can unmute and ask your question directly.
Yes, sorry, I couldn't use the question and answer. Yes, exactly, right? If you consider exposures in the third trimester for those with preeclampsia up to the time of preeclampsia, which can be preterm, so it could be at most 40 weeks, but usually under 37. And then the ones that do not have preeclampsia are followed not only until delivery, but sometimes even later, then the opportunity to get the prescription for those with preeclampsia is going to be shorter weeks, fewer weeks or days.
Oh,
therefore, with no associations, you will expect a protective effect by design.
Oh, so okay, thank you for the question, and I hope this will answer your question. We stopped the follow-up at the not until the delivery date. We for all the termed pregnancies as well, we just stopped assessing. We stopped the exposure time window until the 245 days for all the termed pregnancies as well. So I guess by defining the third trimester, by ending the exposure window at 245 days would eliminate that potential bias, maybe.
Okay, yes, thank you. I thought that you had said that for preeclampsia, you only counted until the event, which could be shorter, but I might have misunderstood. Sorry. Okay, thank you.
Sorry, thank you.
Okay, there's another question by Angela Lupatelli that goes in a similar direction. So I'm hoping that has been answered. There's one quick question by Sasha Dublin, and I'll take this as the last question for this particular talk. Did you have any ability to look at individual drugs separately? I think some of the early animal studies focused on esomeprazole as the potential agent that might reduce risk.
Yes, thank you for the question. And actually, we conducted the analysis to look at the individual drugs' effects separately. But as you might see in my slides, prevalence was relatively low. The preeclampsia prevalence and also the preterm preeclampsia was relatively low in our population. So there were like the estimates were very imprecise when we separated the individual drugs. So we found that these are not meaningful in our report. So that's why we did not show the results of the individual drugs.
Okay. Well, thank you very much, Ayung. We will move on to the next talk. The next talk is by Andrea Komistek, and she will discuss the validity of ICD-10 Z3A codes for estimating date of last menstrual period.
Thank you. All right, so on behalf of my co-authors, thank you all for attending this presentation today of our
I
work.
cannot see your slides yet, just your video.
Let's see, sorry about that.
Mhm.
Oops.
There we
All
go.
right.
Thank you.
Oh, so you see my video, my slides now?
Yes, perfect.
Okay, great. Sorry about that. On behalf of my co-authors, thank you all for being here today and for listening to our presentation on validity of ICD-10 Z3A codes for estimating date of last menstrual period. These are our disclosures. So claims databases are increasingly used to evaluate medication safety during pregnancy. To study the impact of a drug on pregnancy outcomes, there is a need to accurately estimate pregnancy start date. Unfortunately, direct measures of gestational age are not available in claims data. The introduction of ICD-10 codes for gestational age provides an opportunity to improve upon earlier algorithms for estimation of date of last menstrual period. As such, the objective of this study was to validate ICD-10-based claims algorithms that utilize Z3A codes to estimate LMP date against medical records. This study used data from Optum's Dynamic Assessment of Pregnancy in Infants, which is a pregnancy database within a health insurance claims data source. The base population included women with a pregnancy between January 1st of 2016 and December 31st of 2017. We further restricted women with continuous medical and pharmacy coverage for at least 6 months prior to pregnancy through the end of pregnancy. The algorithm to estimate LMP date utilized all available codes indicating weeks of gestation. Z3A00 and Z3A01 are nonspecific codes. They were included in order to identify pregnancy episodes that only had one or both codes, as these codes may be the only ones present for pregnancies that ended in a loss or termination. Codes Z3A08 through Z3A42 specify an exact week of gestation, as you can see in the table. Code Z3A49 was not included in the algorithm since it was rarely observed and was not associated with a specific gestational period within our data. For each woman and for each observed Z3A code, the algorithm subtracts the weeks of gestation indicated by the Z3A code from the date of service indicated in the claim to estimate LMP date. For example, if the service date on the claim was July 10th of 2019 and the claim had a Z3A10 code, the algorithm would subtract 10 weeks from the service date, resulting in an estimated LMP date of May 1st of 2019. These LMP date estimations are repeated for each available Z3A code, resulting in multiple estimated LMP dates for each woman. So then, to identify pregnancy episodes, all LMP dates within 6 weeks of each other are grouped together. The 6-week window was chosen based on the minimum number of weeks required between pregnancies from previous publications. The final data cleaning steps remove the nonspecific Z3A codes and the associated LMP date estimates if specific Z3A codes are present within a cluster. The LMP date for each pregnancy episode was then estimated using 2 methods. The first was the LMP date from the first observed Z3A code based on the service date, and second, the median date based on all Z3A codes within a pregnancy episode. For the subset of pregnancies where Z3A codes were not observed, algorithms informed by published literature and refined following clinical input were used. The estimated LMP was calculated based on lengths of gestation for pregnancy outcomes, ranging from 8 weeks for trophoblastic diseases in ectopic pregnancies to 39 weeks for full-term singleton births. This study was conducted in the context of a pregnancy outcome validation study that was included as part of a larger safety study. As a result, estimated LMP date was validated among 205 maternal charts procured for the validation of adverse pregnancy outcomes, which may represent pregnancies that are challenging to date. The charts were from 86 live births and 119 non-live births. Adjudication was performed by an epidemiologist, and final date of LMP was based on all information in the record. Consequently, if LMP was not specified in the chart, but gestational age and service date were present, LMP was calculated. So this graph is showing the difference between estimated median LMP based on all Z3A codes and adjudicated LMP. The x-axis is categories of the number of days difference, where 0 indicates that estimated LMP date and adjudicated LMP date were the same. Negative values occur when the estimated LMP based on Z3A codes was earlier than the adjudicated LMP, whereas positive values indicate that the estimated LMP was later than the adjudicated LMP. The dark orange bar represents the results for all pregnancy overall, while the other bars indicate the individual pregnancy outcomes. Overall, the median LMP date was plus or minus 7 days from the adjudicated LMP date for 65% of pregnancies. According to pregnancy outcome, median LMP was within 7 days of adjudicated LMP among 34% of pregnancies with spontaneous abortion, compared to 90% or more among pregnancies with premature delivery, placenta previa, or preeclampsia. A pattern that is evident in the graph is that estimated median LMP date was more likely to be later than the adjudicated LMP date for the majority of pregnancies. So why does estimated LMP tend to be later than adjudicated LMP? One reason is that the Z3A code typically indicates completed weeks of gestation. As an example, we have a patient whose adjudicated or actionable LMP date was February 20th of 2017. She visited the doctor on May 7th, 2017, when the gestational age of the fetus was 10 weeks, 3 days. Consequently, an ICD-10 code of Z3A10 appeared on the claim for this office visit. Based on the Z3A10 code and the service date, her estimated LMP was February 23rd, 2017, which is 3 days after her adjudicated LMP date. This table presents the results for each of the 3 methods that were used to estimate LMP. There were 157 pregnancies that had at least one Z3A code present in their claims, and 48 pregnancies without Z3A codes, of which 46 ended in spontaneous abortion. This table shows that both Z3A approaches performed well. The median LMP based on all Z3A codes was a little more accurate for pregnancies with premature delivery, placenta previa, and preeclampsia, whereas the LMP based on the earliest Z3A code was more accurate for spontaneous abortions. Estimated LMP was less accurate for pregnancies without a Z3A code, the majority of which ended in spontaneous abortion. So in this study, we found that the two LMP algorithms based on Z3A codes perform well for pregnancies resulting in a live birth. However, the LMP algorithms did not perform as well among pregnancies that had a chart procured for a spontaneous abortion. Development of a claims-based algorithm for estimation of LMP among cases of spontaneous abortion is challenging. The first specific Z3A code is Z3A08, which is 8 weeks of gestation and pregnancy, which is consistent with when many women have their first prenatal visit. Prior to 8 weeks gestation, the non-specific Z3A codes are used, for which we assign 4 weeks gestation in this study. As most miscarriages occur prior to the 12th week of pregnancy, it is possible that women whose pregnancies end in spontaneous abortion may not have any Z3A codes observed in their claims or have only non-specific Z3A codes, resulting in less accurate estimation of LMP date. A limitation to the generalizability of the study was that all of the medical records adjudicated for LMP were from pregnancies that had a claim for an adverse pregnancy outcome. However, pregnancies with a claim for premature delivery, placenta previa, and preeclampsia often had multiple Z3A codes observed during pregnancy, which likely improved estimation of LMP. We would expect the accuracy of estimated LMP date among uncomplicated pregnancies to be similar to that among the pregnancies in this study, with a claim for premature delivery, placenta previa, and preeclampsia, due to the high probability that multiple Z3A codes would be observed within a full-term pregnancy. In conclusion, claims-based algorithms utilizing Z3A codes accurately estimated the LMP date observed in medical records. This study helps to highlight areas for future research to facilitate the utilization of claims databases for pregnancy safety studies. Thank you for your attention.
Thank you, Andrea. While people are typing their questions, I'm going to ask one.
Sure.
It was very informative that you illustrated how the codes code for completed weeks of gestation,
Sure.
while in reality, we are somewhere in between.
Yep.
Did you consider a sensitivity or a post-hoc analysis where you just would pick that midpoint? So let's say 10 weeks plus 3 days and apply those 3 days to every pregnancy. So in essence, you would shift the entire figure that you showed on slide, I don't remember the number, by 3 days.
Yeah, no, yeah. So, right, so you're saying instead of assigning 10 weeks gestation for like a Z3A10 code, we would assign like 10.5 weeks gestation.
Sure.
We haven't discussed that. I'm not, yeah, that would be an interesting sub-analysis to do to see if it improves our estimation at all. I'm wondering, the only, like, I feel like there's women that are in a range of this, you know, they're 10 weeks, you know, 0 days to 10 weeks, 6 days. So I wonder if it would just kind of average out either way. There's going to be a little bit of error either way, but no, that's a really good suggestion.
Well, in theory, it should shift them into one direction because they are not rounded, right? These are completed weeks, if the code is coded correctly. And I'm not sure whether the midpoint should be the point because on average, you know, most of the gestation duration is around 39, 40 weeks. So I think most of the women will be slightly to the higher, not the midpoint. So it may be 10 weeks and 4 days, 5 days, I don't know. Just as a thought to see how much that changes. Good. There's one question by Henida Rufius. What happened with stillbirths? Did you make a conscious decision to exclude those?
That was not one of the stillbirths. So for that larger pregnancy validation study, we did include stillbirths, but for stillbirths, we had charts procured for infants. And so we needed the women's charts to be able to pull LMP date, to be able to adjudicate LMP date. So that's why stillbirth wasn't used.
Okay. We have time for one more question from Yanmin. Thank you for the talk. Have you looked into the prevalence of the codes used in the database? I wonder how many pregnancies have no such code and rely on the other part of the ALG to estimate GA, gestational age.
Kind of saying in the whole database, how many pregnancies have Z3A codes? Is that the correct question?
Possibly, and what the prevalence of the various codes is. Yanmin, maybe you, Yanmin says yes. So yes to your interpretation.
Sure. So yeah, and I should have the statistics memorized off the top of my head, but I don't. A very high proportion of pregnancies actually have Z3A codes. I want to say it's upwards of 70 or 80%. I would have to double check though. So most of them do have, a lot of them do have Z3A codes, which is fortunate since I think Z3A codes are really helpful. Was there a second part to that question?
Similar. I wonder how many pregnancies have no such codes and rely on the other part of the ALG to estimate GA.
So I think it's upwards of 70 to 80% have Z3A codes, and then the remainder rely on that outcome-based approach to estimate LMP.
Okay, great. Thank you, Andrea.
Sure.
We will now move on to the last speaker for today, Sonia Hernandez-Diaz. She will talk about COVID-19 pharmacotherapy during pregnancy, International Registry of Coronavirus Exposure in Pregnancy, or ICE. I'm going to let you pronounce that.
Yeah, thank you. It's nice to see you all. I'm going to talk about COVID in case you were missing that in the presentation today, and about the utilization of medications for it during pregnancy. The study received support from Johnson & Johnson and Regeneron. I did not get any funding for this work, but I have received funding from other companies for unrelated purposes in the last years. So patients that are pregnant do get infected with coronavirus, and when they do so, they develop severe illness in a proportion that can be between 5 and 10% of the cases. And not only they get all the risk from the disease, but because of the pregnancy, they also have obstetric risks such as preterm delivery. Therefore, they need to be treated sometimes, and they have been treated sometimes. And these treatments, as you know, include some medications that have been used for other things in the past, as well as newly identified therapies. And for the medications that have been used before for, say, lupus or HIV, we have some information. For the new medications, we have little information. And we also have little information for the patterns of utilization. And that's what I'm going to present today, the utilization data using the International Registry of Coronavirus Exposure in Pregnancy, IRCEP, which is a collaboration between the Harvard School of Public Health and pre-registry. The study is an ongoing international observational cohort that it has been translated to 11 languages and enroll participants directly through social media using a web and an app, and collect the information online directly from the mother. And the inclusion criteria are being 18 years of age or older, pregnant or recently pregnant in the last 6 months, or and having a clinical diagnosis of COVID-19 conducted by a healthcare provider, or results from a test for the coronavirus during pregnancy, regardless of the results of the test, because the negative results are used for as a control for some of the analysis. The follow-up includes monthly contacts throughout the pregnancy and up to 90 days after birth for the live births. And during that time, we collect information on a variety of topics, in particular, detailed information on the coronavirus infection and the COVID-19 symptoms, treatments, and the resolution of the condition. We also collect data on baseline characteristics, on them obstetric and neonatal outcomes up to 90 days of life for live births, and other things like healthcare access, well-being, or mental health. We are going to focus on medications today, so here I wanted to present the specific questions that are asked for medication. Did you take any medication during pregnancy to treat COVID-19? We asked this medication if they reported having COVID-19. And if yes, then we provided a series of medications that are not mutually exclusive, so the participants can select more than one. And then we have the option other with an open text, and we have cleaned that information to group them for the presentation today. The participants enroll from any country, but the number of participants is correlated with the Facebook awareness efforts that were also correlated by the intensity of the pandemic in each country. So the countries that you see in this table are the ones with the top number of enrollees and are also among the top in terms of number of cases during the pandemic. So we have the US, Brazil, the UK, Russia, Mexico, Spain, and India among the top, for example. And at the time of the analysis, we had over 17,500 enrollees, over 50% of them enrolled during pregnancy and the rest right after end of pregnancy. For this particular presentation today, we included only those women in the cohort with a diagnosis of COVID-19 during pregnancy based on either a positive test laboratory or a clinical diagnosis of COVID-19. Around 3% of them didn't have a test because it was not available in their countries at the time of infection, but results do not change when excluding those 3% among the symptomatic. And we are going to present only the symptomatic individuals, therefore, and categorize them as mild, moderate, or severe following the NIH recommendations that are also the ones that we're using the clinical trials for treatments. So in severe, we will have those that require admission to the intensive care unit or need respiratory assistance, including ECMO or a ventilation with high oxygen, and that were hospitalized with severe things like organ failure or pneumonia with respiratory distress symptoms, etc. The others that were severe but not so severe will be moderate and mild, are the typical symptoms that do not require going to the hospital, of course. The study population is ethnically, racially diverse, with an average mean age of around 30. And we'll see infections throughout pregnancy with around 30% in each trimester. And the categories that we use for severity ended up classifying 6.4% of the symptomatic COVID cases as severe. Now we are presenting a table with the utilization of medications stratified by mild, moderate, and severe in each column, and they are organized alphabetically. So if you want to see a specific one, just wait for the slide with the name. But other than analgesics and antibiotics, we observe the medications that others have observed outside pregnancy. So for example, azithromycin, we see that among the severe, 27% of the participants reported it, and lower in mild and moderate. For anticoagulants, also 9% of the severe reported using them or being treated with them during pregnancy. Alphabetically, we continue and we see pregnant women were also treated with chloroquine, hydroxychloroquine during pregnancy. We also see Tamiflu or Seltamivir at the top with 6.5% of the severe exposed. Remdesivir, a total of around 20 exposed during pregnancy in this cohort, and then dexamethasone and other steroids, corticosteroids, were also commonly used in this population. So overall, most of the COVID-specific treatments are more common in the severe. Not all of them, but most of them, which I think is important for when we get to study the safety of these medications during pregnancy, that the severity is going to be associated with the utilization. So we want to be careful with that. Regarding the timing of pregnancy, when we look at the severity by trimester, first, second, and third, we observe that the proportion of severe, according to our classification, was higher in the third trimester, 9.8% of the cases, than in the first trimester. So the numbers, as you can see in the last row, get a little bit smaller, but what I'm going to show now is the distribution of medications in the severe one, in the last row. For the first, second, and third trimester, within the severe ones, we see that based on relatively small numbers, if anything, they are both more severe cases and also a higher proportion of exposed to these medications in the third trimester. Regarding the patterns for different countries, we saw some diversity, and I would like to highlight that, for example, interferon was used mainly, like almost only in Russia, while remdesivir was preferentially used in the United States, in the US, even when we see some use in other countries as well. So in summary, we observed that the most commonly reported COVID-19 therapies other than analgesics were azithromycin, dexamethasone, interferon, oseltamivir, chloroquine, hydroxychloroquine, antihistamines, and antibodies during pregnancy, excluding analgesics and antipyretics, of course. And that most therapy usage increases with severity of disease, although not all. And that among severe COVID-19 cases, which are more common in the third trimester, the later trimester patients reported higher use. So that means that we have few exposed to these medications in the first trimester, which might be a good thing, but also might indicate that potentially the use was restrained early in pregnancy, maybe, this is a hypothesis, that maybe over concerns of teratogenicity or other complications. And some countries accounted for high proportions of some of the medications, more likely because of the differential approval or availability of the medications in different countries. I would like to highlight some of the limitations of this study. The data is collected via self-reported questionnaires, so there is a risk of underreporting and some degree of misclassification and confusion between medications. Some women indicated, for example, that they were taking medications that we will not generally consider for COVID. A small proportion reported things like antidepressants or hypertension medications that can help, but are not considered specifically for COVID. And finally, we had some missing data for some variables. Some of them were useful for this analysis, for example, the specific gestational age diagnosis for some patients. In conclusion, the participants reported the use of medications for COVID-19 during pregnancy, for which we have little safety information. And observational studies, including these registries or database studies, will be able to contribute evidence on the safety of these therapies that have been used and will be used for COVID-19, as well as for vaccines during pregnancy, particularly while pregnant women are excluded from the pre-marketing clinical trials. And so I think that even when the use is not huge, since the number of cases around the world is high, there is a need to generate and communicate valid evidence on the safety of these medications during pregnancy. Thank you.
Thank you, Sonia. I don't see any questions in the Q&A box, but I do have one question. Your study did not include a cohort of non-pregnant women, and probably for good reason. But I'm wondering, based on what we know about drug use in the general population, are there any individual drugs that stick out as being used more often than you would expect or less often than you would expect if we look at the general trends?
No, based on the studies that I found that were mainly from the US and Europe, the top medications were the top medications in both pregnancy and non-pregnant women. I think, if anything, maybe hydroxychloroquine, depending on the time period, might have been more common, but I think that might be because of the use before in women with lupus. Maybe clinicians felt more confident using that medication during pregnancy. But okay, yeah, in general, the patterns extend into pregnancy.
Mm-hmm. Great. Well, thank you very much. This concludes our session. I think it was a very interesting session with many clearly presented presentations. I want to thank the presenters. I want to thank the audience for their active participation. And wherever you are, have a good afternoon or good night.